So the principles of surgery is resection with clear margins so that the primary tumor is totally treated. Then comes neck dissection. So appropriate neck dissection has to be done for all patients. We have seen even by trials by Tata Memorial Hospital Mumbai that they have observed few early cancers without having done neck dissection, and they found out at the end of the trial that doing an elective neck dissection improves the overall survival and disease-free survival, and also that even if they have observed the neck, the recurrences that happen in the neck are much worse than the normal neck dissection if they are done in a first setting. Then the third thing that we have to see is reconstruct what you resect. That is, whatever part you have taken out, we have to make sure it is replaced. And replacing should always be like for like. So if you are removing soft tissue, you have to replace with soft tissue. If you are removing the bone, like the mandible or maxilla, it is ideal to replace it with bone. Okay, but all these surgeries are modified according to the age, comorbidities, affordability, defect, and the neck disease. So now the resection is all based on which part of the oral cavity has the cancer. So the tongue, depending upon the size of the lesion, it can be partial, hemi, total, or subtotal glossectomy. Glossectomy is the term for resection of the tongue. For buccal mucosa, it has to be either just a wide local excision, a marginal mandibulectomy, segmental mandibulectomy, infrastructure maxillectomy, or total maxillectomy as per the defect, as per the lesion of the buccal mucosa. Bite resection, ITF clearance. These are the things that we have as terminology for different lesions of the buccal mucosa, and skin defects are also present. So during the surgery, we have some morbidity. I'm not going into the details of each surgery because that is a separate topic altogether. So what we are seeing is the morbidity that can be present with the present treatment options. So the problem is when we do a total glossectomy or a buccal mucosa resection, there is a chance of aspiration because we are doing neck dissection and sometimes reconstruction with the pectoralis major flap. There will be shoulder pain and chest pain, and the donor site defects will be there if they don't heal properly. And post-op, if they are going for radiation, there will be the side effects because of radiation that are always there. These are all either reversible, preventable things that are there. Shoulder pain, usually all the patients get, but it can be treated with some physiotherapy and exercise. Aspirations are totally preventable, and radiation effects are irreversible, and sometimes they are considered as the sequelae of the effect of the radiation. So facial deformity, we try to minimize as much as possible. You will see in the further slides how the modern day surgeries have changed the outlook of the patient at the end of the surgery and end of the treatment. The speech defect will be there, and sometimes it is helpful with reconstruction that we are able to manage with minimal defect. Swallowing trismus is always there, and the worst thing is that oral cancer patients, because of field cancerization and other issues like that, there is always a lurking chance of recurrence somewhere or the other in the body. So I will discuss a few patients that I have operated on in the past 1 year or so. So this is a patient of growth in the upper alveolus, that is the palate. Okay, she was an 81-year-old lady. She is a 82-year-old lady now, and her only complaint was that she was having foul smell from the oral cavity because she is hard of hearing and doesn't talk much to her attendants. Nobody was able to diagnose her at an early stage except for when her daughter was leaning forward to talk to her something to her, she smelt that there is some bad odor coming. And when we examined her oral cavity, there was a growth in the oral cavity. Because of her age and comorbidities, we just did a upper alveolectomy and neck dissection. We left the defect raw for using a implant later on. We can get the implant done by a maxillofacial surgeon or prosthodontist. This is a buccal mucosa patient. It was a T1 lesion. We did a wide local excision and a buccal pad of fat reconstruction and a neck dissection. You can see this is the post-op picture, and you can actually not make out that the patient has had any surgery or the patient had any cancer of any sorts. He is doing perfectly fine as of now. This was a T2 lesion in the tongue, or I think T1 lesion. The only issue was he had a lot of nodes in the neck. So even if the primary is small, the nodes in the neck can be multiple and can be uh, multiple, and it can be positive, and that she required an adjuvant therapy. And such kind of disease generally is having a poor prognosis, which is having a small primary and multiple nodes in the neck. That means the disease biology itself is very aggressive, and that causes for us to escalate the treatment whenever we are doing. So the patient received post-op radiation and chemotherapy, but still the patient had recurrence at the end of the treatment. After 6 months of the treatment, he had recurrence again, for which we could not operate because it was metastatic. So now these were the smaller lesions which did not require much of reconstruction. So when we require reconstruction, we do the following reconstructive flaps. Either it will be a local flap, which can be harvested anywhere around the oral cavity, that is either the cheek or the submental region or in the neck somewhere. And those flaps can be used to reconstruct the defect. And then comes the regional flaps, which will be usually taken from the chest or the forehead, and they are used for reconstructing the defects. And then free flaps. It is just a misnomer that it's a free flap. It's not actually done for free. It is quite a costly this thing, and usually the plastic and reconstructive team will come along with the surgical oncologist, and we will be doing them along with it. It is called free because it is a free tissue transfer. That is tissue from somewhere else, a distant site. Either it can be a forearm, or it can be from the thigh or of the abdomen. It can be used along with its blood supply and anastomosed to the blood supply in the neck, so that the tissue will gain blood supply and it can be used for reconstruction. So this is a T4A upper lip tumor. We did a local advancement flap. Only the advancement flap was done and the defect was covered. The main advantage for this was it is reducing the amount of morbidity because of reconstructive procedures, and also because it is the upper lip, it may look a bit different just in the post-op period, but overall after it heals, it becomes much better and it causes the competency of the oral cavity. So this is a floor of mouth lesion, which was T2. The issue with floor of mouth defect is that when this defect is present, this is the site of the defect, which we have closed with the flap. The issue is it is not as big as which will require a reconstruction to cause the function. But the problem is it causes communication into the neck. When we do the surgery, the the partial glossectomy is done, and along with that neck dissection is done. So there will be some defect which will be communicating into the neck. So whatever the patient will eat, if this is not reconstructed, it will come down into the neck, right? So to cause a bridging, we need to use this flap, and this flap was engineered by my teacher, Dr. Chandrasekhar, and we call it the CFAM flap, that is cervicofacial artery based myocutaneous flap. And this flap is harvested based on the facial artery. You can see the artery here and the vein here, and this flap is totally inserted inside. This is a verrucous lesion of the buccal mucosa, which was T2, and we reconstructed it with pectoralis major flap. You can see in the first image that actually you can't make any difference as if the flap has been placed inside, unless the patient opens his mouth or he opens his shirt like Salman Khan, right? And this is the other patient of a T3 tongue lesion. We had operated on him last year, and after that he had taken radiation. This was also reconstructed with a pectoralis major flap harvested from the left side. You can see the flap here, okay? But once he closes his mouth, and his neck and mouth are almost as normal as any other person. So these are the lesions which require reconstruction for sure. That is, the alveolus has been totally involved and it requires a fibula reconstruction. I can show you the image here. This is the image of the same person that I was showing you that time, and this is a image of another person, which is mouth open, and then I can show you that. In this, we have reconstructed the loss of the alveolus with the fibula free flap. Okay, and overall, after the reconstruction, the patient will have normal mouth opening function, and also the patient can go for dentition after the healing is done. This is a FAM flap, that is a platysmal flap, and it is harvested from the neck dissection site and used for reconstructing the floor of mouth, just like we have done in the CFAM flap.